Hello, I'm Professor Paul Sidhu from King's College Hospital in London, and I will talk to you about contrast-enhanced ultrasound of focal liver lesions. First of all, a bit of the background on the value of using contrast-enhanced ultrasound, or CEUS, in the diagnosis of focal liver lesions. I'm going to base most of my talk on the recommendations and guidelines from the European Federation of Societies in Ultrasound in Medicine and Biology, who have been at the forefront of establishing the clinical practice worldwide on the use of CEUS in assessing the focal liver lesion. First of all, I'd like to draw your attention as to why we should be using contrast-enhanced ultrasound over other imaging modalities, particularly over CT and MRI, where CEUS has distinct advantages. Contrast-enhanced ultrasound can be performed immediately without any preliminary laboratory testing. It can be carried out in a variety of scenarios at the bedside, in the operating theatre, or with CT examination concurrently. Importantly, it operates in real time so that rapid changes can be captured. And so this is the advantage that ultrasound has over many other modalities, in that there is no ionizing radiation, there's no contrast reactions, there are no adverse events that occur with the kidneys, and also it is also relatively inexpensive. What about the safety of contrast-enhanced ultrasound? Well, SonoView, which is the agent that we are predominantly using, is truly intravascular, not excreted by the kidneys, made up of a phospholipid shell and sulfur hexafluoride gas, which is broken down in the liver, and the gas is exhaled via the lungs. So it is a very inert compound. It is truly intravascular, so if there is vascularization of any area, this contrast will be seen through that lesion. And this is important, particularly in the evaluation of vascular or avascular focal lesions. The safety has been established in a number of publications, most notably the publication from Italy where 23,000 patients were examined and there were no adverse effects of note. Post-surveillance of the use of SonoView by Bracco has established that there is very little severe anaphylactoid reactions and only 0.0006% fatality related to the use in stress cardio echo. This compares with the fatalities recorded with CT iodinated contrast of 0.001%. No agent is completely safe. We also have to establish whether or not contrast-enhanced ultrasound is actually useful. What is the evidence that it is actually sensitive and specific for focal liver lesions? The table is taken from a recent paper by Richard Barr looking at contrast-enhanced ultrasound for focal liver lesions and how particularly accurate it is. Remember, very often you're comparing unenhanced ultrasound to enhanced CT examination to determine whether or not ultrasound is sensitive or specific for the evaluation of a focal liver lesion. Well, first of all, let's compare unenhanced ultrasound to contrast-enhanced ultrasound. How good is contrast-enhanced ultrasound in comparison to this baseline examination? Well, there are two studies here, and I'm going to highlight the study by Quare, looking at 452 patients where the sensitivity of contrast-enhanced ultrasound in comparison to baseline ultrasound increased from 52 to 81%. And similarly, the specificity from 40 to 95%. So clearly just adding contrast in the evaluation of a focal liver lesion renders or doubles the sensitivity and specificity of the examination. And this is very important because ultrasound had previously been thought as limited in the evaluation of focal lesions. What about comparing contrast-enhanced ultrasound to contrast-enhanced CT? Well, always remember that if you can see a lesion with ultrasound, you see it best of all because there is superb temporal resolution and there is also superb resolution with B mode anyway in these lesions. So let's look at the study from CEUS, in the Degum multi-center study, looking at the accuracy of contrast-enhanced ultrasound compared to contrast-enhanced CT. And you can see here that CEUS outperformed CT both in the sensitivity and the specificity of a focal lesion. So the evidence is there that it's both sensitive and specific. It is better than baseline ultrasound and is equivalent to a contrast-enhanced CT. And how good is it at characterizing various liver lesions? Well, it's very good. It's very good for hemangioma, focal nodular hyperplasia, and both malignant lesions such as HCC and metastases. And the conclusion in Richard Barr's study was that the literature suggests that widespread use of contrast-enhanced ultrasound is appropriate for focal liver lesions. And in the USA, the standard of care needs to change to include contrast-enhanced ultrasound for characterization of focal liver lesions. In the German healthcare system, these two papers demonstrate, first of all, that it's equal value for the differentiation and specification of newly diagnosed liver tumors in clinical practice, and it's extremely useful for differentiating benign from malignant lesions and for characterizing hemangiomas and focal nodular hyperplasia. And in the German healthcare system, it's also cost effective. It stops downstream costs of further MRI or CT examinations or physician appointments for examination and appraisal of the lesion. So we've now got an agent that is very good at characterizing both specifically and sensitive of focal liver lesions, and it is also inexpensive in comparison to the other imaging modalities. So let's just pause for a moment and think about this philosophically. No self-respecting radiologist would report an unenhanced CT in a cirrhotic patient. You will want to have contrast administered to pick up that HCC. However, very often, as a radiologist, you would stop at the B-mode ultrasound when you see an echogenic lesion, which is a hemangioma in this case. Adding contrast here will tell you that there is no washout in that lesion, so it's definitely not malignant. And lesions here are demonstrated very clearly with contrast-enhanced ultrasound to show the washout of malignancy. So there are different reasons you use contrast in these two imaging parameters, but you're not on an even playing field comparing the unenhanced ultrasound with an enhanced CT. In effect, the two unenhanced figures should be comparable. So let's have a quick look now at the EFSUMB guidelines, and you should base your various clinical practices in this area on the guidelines. They're very comprehensive, detailed, and give you a good direction in which to follow. The EFSUMB guidelines started out in 2004 with the first guidelines issued, with a follow-up for focal liver lesions in 2008. Then in 2011, EFSUMB published the non-hepatic applications, and this was a landmark publication because the licensing for SonoView and other contrast agents is for the liver, peripheral vascular, breast, and echo. But this was a learned society producing guidelines on using contrast-enhanced ultrasound outside licensing, which is fine because if you take responsibility as a physician and your patient agrees to this application, there is no issue for using it, particularly if it's evidence-based, and the guidelines prepare you for this. 2012, there was an update on focal liver lesions, and then subsequently a little bit more branching out in different directions. There was contrast-enhanced ultrasound again in non-hepatic applications and also in pediatrics. And more recently, contrast-enhanced ultrasound is being used in classifying Bosniak cysts and producing the EFSUMB pediatric CEUS registry for looking at the use of contrast-enhanced ultrasound in children. And most importantly now, in 2016, the FDA in the United States approved the use of contrast in focal liver lesions, both in the adult and the pediatric patient. So its use is widespread. And more recently, these are the most up-to-date guidelines on the use of contrast-enhanced ultrasound in focal liver lesions. And there is plenty of evidence now for you to begin practice or consolidate your practice. The new guidelines had 38 recommendations from the level of safety right round to the level of knowledge of artifacts associated with the use of contrast. 20,000 words, 281 references, and 38 world experts. Sonoview, which is the ultrasound agent that we use mostly in Europe, is widely available throughout the world. And the only areas where it's not licensed for use is not so much because of issues of safety or things like that, but is actually a commercial decision. So how do you use contrast-enhanced ultrasound to diagnose focal liver lesions? Well, it's exactly the same as you would do in CT. You're looking for the arterial phase of hyperenhancement, which starts very early, portal venous phase, and then the late phase with bubble disappearance. And this is seen both in CT and MRI as well as contrast-enhanced ultrasound. But the difference between these modalities is that the contrast agent in ultrasound is truly intravascular, and you are looking at true washout and true hyperenhancement. There is no equilibrium phase. And of course, it's all due to the dual blood supply in the liver, both the hepatic artery and the portal vein, that these different overlapping stages and phases are useful in making the diagnosis. Let's quickly look at some benign liver lesions. The most common lesion you're going to be seeing is a cavernous hemangioma, and quite often they're not quite so as large as this, but pretty characteristic in being echogenic and close to the liver surface. This is changing with the current demographics of patients where fatty livers render the increased echogenicity of the hemangioma less obvious, and quite often these lesions are isoechoic or even hyperechoic to the liver. But the characteristic infilling and globular enhancement and gradual disappearance of that lesion is easily visualized with the contrast-enhanced ultrasound as you're watching it in real time with no danger or detriment to the patient's health, and you can watch that disappear completely. Contrast that with a CT examination where snapshots in time are produced, and of course, each time you're producing a CT examination at a different phase of contrast enhancement, you're subjecting that patient to radiation. In ultrasound, you get the same information in real time over 3 or 4 minutes with minimal discomfort or increased morbidity to the patient. It's not just radiation. The contrast burden from iodinated contrast and renal impairment is something to bear in mind. The next most common lesion is the focal nodular hyperplasia, and the hallmark of this is the arterial enhancement at the beginning of the examination. Here is a very atypical focal nodular hyperplasia, but it's that hyperenhancement at the beginning and the remaining hyperenhancement through the portal venous phase and possibly a small scar. That's the clue. The very beginning, that spoke wheel enhancement is characteristic. A hepatocellular adenoma behaves slightly different. It is usually hyperenhancing and remains hyperenhancing throughout the various liver phases, but the pattern of arterial enhancement is usually from the peripheral to the center rather than the center outwards. There are some caveats with adenomas depending on the cell type, and 1 or 2 of these cell types actually do show some late washout. An abscess is picked up very clearly on contrast-enhanced ultrasound, the septations with the areas of avascularity demonstrating the presence of infective pus in these areas, and you can use the contrast-enhanced ultrasound to direct drainage of the focal fluid areas safely. Another benign lesion is the focal fatty sparing, which traditionally has been suggested is iso-enhancing through all phases of the liver enhancement pattern. However, recently our group has shown this is not quite so true. In areas of focal fatty sparing, for instance, the contrast enhancement shows significantly lower and slower enhancement than the normal parenchyma, whereas focal fatty infiltration enhances identically. Why this should happen, we're not sure, but there's a clear difference between the enhancement patterns, but it doesn't deter from the fact that these lesions do not wash out in the late phase and therefore are benign. Malignant focal lesions behave differently. The most common lesion you're likely to encounter, unless you work in a large tertiary referral cirrhotic liver disease hospital, is the metastases. And the hallmark of the metastases may be that they may be hyper-enhancing with rim enhancement, but it's the rapid and clear washout in the early portal venous phase and persisting into the late phase. And this is very characteristic of metastatic disease. HCC behaves a little bit differently. Very often the HCC is hyper-enhancing and remains hyper-enhancing in the early arterial and early portal venous phase and takes some time to wash out. In this patient, the washout is slow and late and incomplete, whereas metastases are complete. So after 4.5 minutes, nearly 5 minutes, you're starting to see washout in the HCC. And this is very important to bear in mind, that if you are examining a hepatocellular carcinoma, pay particular attention to the washout in the very late phases. You may be scanning for 5 minutes to 6 minutes. The guidelines tabulate all these different features of different focal lesions very clearly for you to practice and refer to and look at the degree of washout in hyper-enhancement and the patterns that are predictable for certain benign and malignant lesions. Draw your attention also to the recent publication of the American College of Radiologists, CEUS LI-RADS working group, which stipulate how you should be assessing and looking at HCC in this group of patients for better delineation and better referral patterns for these lesions. But recommendation 16 in the guidelines indicate that it can be used as a first line to characterize focal liver lesions and liver cirrhosis to establish a diagnosis of malignancy, and this is LRM or HCC LR5. But CT and MR remain required for accurate staging because you're only looking at the lesion with contrast enhanced ultrasound. So it's important to remember in HCC there's a feeding artery and hyper enhancement in the arterial phase, maybe with basket pattern chaotic vessels. You may see thrombus in the hepatic or portal veins, or non-enhancing lesion, rarely in an atypical lesion. And then over time in the light phase, you may see hyso-enhancing or hyper-enhancing of the lesion, but it sometimes may take quite a few minutes to achieve that washout. And this is the table of how you would classify contrast-enhanced ultrasound LI-RADS, ranging from those normal, benign, LR1, LR2, the clearly malignant LRM, and then 3 classifications of HCC from intermediate, probable to definite. And the findings of benign lesions are very distinct and have been described a little bit earlier. So how do you classify the presence of an HCC in a cirrhotic liver? And remember, this is classification within a cirrhotic liver. Well, you're looking at the size of the lesion. If the lesion is greater than 10 millimeters, it's hyper-enhancing and there's washout, then it's a definite LI-RADS 5. And therefore, with the changes in size and also the hyper-enhancing or no hyper-enhancing, you classify them differently. So really, it's a late and mild washout, hyper-enhancing, and bigger than a centimeter, you've got an LR5 or a definite HCC. And this is the algorithm to follow for imaging your injection, and you intermittently image over that period of time, because if you continuously image over that period of time, you burn out and the lesion becomes washed out prematurely or inaccurately, and you will make a misdiagnosis. Well, most often you're going to be scanning a patient with a focal liver lesion that's an incidental liver lesion. It's unexpected. What do you do with it? Well, the teaching is that you should, in all these cases, be giving contrast-enhanced ultrasound to diagnose and specify what sort of lesion you're dealing with. How often do you see an incidental lesion? Well, this is a study from Newcastle, which looked at over 20,000 records from outpatient liver ultrasounds. 9,000 from general practitioners show that 18.4 of focal liver lesions were inconclusive. In 12,500 outpatient records, 1,400 focal liver lesions couldn't be classified on the baseline ultrasound, or nearly 30% were inconclusive. So it's a big patient population that you should be avoiding downstream costs by avoiding CT and MR, by giving the patient some contrast-enhanced ultrasound. How often are these lesions benign or malignant? Well, nearly all of the lesions that you see incidentally are going to be benign. And several studies have demonstrated this over a period of time. So you are very often dealing with a benign abnormality when you see an incidental lesion. And this is important because if you're able to tell the patient there and then that you've examined them accurately with contrast and you are absolutely sure this is a benign lesion, because you can say that because you're very accurate at it, it really does help the patient anxiety and prevents further imaging downstream and further changes to the patient's lifestyle to attend clinic, etc. So here's a couple of examples for you. Here's a patient with a fatty liver and an incidental lesion in the epigastrium. Well, this incidental lesion was subject to a contrast-enhanced ultrasound, and within seconds in the arterial phase, this lesion is demonstrated to have that spoke wheel arterialization, hyper-enhancing with scarring in the middle, and these are the MR and the CT examinations of the patient. This is a focal nodular hyperplasia. You diagnose this at the bedside immediately, but of course the physicians looking after this patient wanted further confirmation with more expensive studies, but over time this will change and they will understand and rely on your contrast-enhanced ultrasound appearances. Here's another patient with an atypical lesion in a fatty liver, examined for upper abdominal pain and gallstones. And here you've got peripheral globular enhancement and infilling of the lesion over time. And this is a hemangioma. These are two patients, both with primary breast cancer, both returning with a focal lesion in the liver. This focal lesion, fortunately, has peripheral globular enhancement and infilling, and it's an atypical hemangioma. This patient, unfortunately, has washout in the portal venous phase, and this is a metastasis. But you're able to diagnose this immediately, establish the pathway management for the patient, and move on as quickly as possible to take care of the patient. So in conclusion, what is the value of contrast-enhanced ultrasound in diagnosis of focal liver lesions? Why do you use it? Well, it's dynamic, it's accurate, and gives you an immediate answer. It negates the need for more expensive downstream imaging. It is patient-friendly and safe in both adults and children. When should you use it? Well, immediately following the indeterminate focal liver lesion that you pick up on your ultrasound examination, but also when CT or MR imaging is indeterminate and it's used as a problem-solving tool. How should you use it? Well, follow the EFSUMB guidelines, and in the United Kingdom, you should follow the National Institute of Clinical Excellence guidelines, where it indicates that it's paramount that you be using CEUS to make a diagnosis of the incidental focal liver lesion. I thank you for your attention.
I think, Paul, you have done a fantastic job. And I think we have also one question from the audience. So the question is funny, but it's of course important. So, did you use contrast in pregnant patient?
Thank you for that question, because I know you can answer it.
Yeah, that's the reason why it's a little bit funny for me.
Yeah, well, let me start off by saying, then I'll hand to you. Yes, you can, because there is a placental barrier that does not allow the contrast agent, which is actually 10 microns across, from crossing the blood, that blood barrier. It's truly intravascular. So theoretically, there should be no issue. But I haven't used it too much, but I know Professor Klevert is going to tell you how he uses it every day in pregnant ladies.
Unfortunately, I don't have every day a pregnant woman, but if there's a lesion we have to handle, then it is very important or very helpful, because you could rule out all lesion. Often you find benign lesion, but unfortunately we also find some cancer in pregnant women, and this is a very sad story, and honestly. Okay, maybe just check whether there's another question. For follow-up in patient with history of liver mets, would you always use contrast?
I would use contrast if it's part of your practice to use follow-up ultrasound in cancer surveillance, you would probably need to use contrast if you can't see any metastases. This is detection. If you see plenty of metastases, then it's got to be restaged anyway. But it's probably good practice to actually inject contrast to make sure you've got no metastases in the liver. But I know this is not widespread practice either.
Okay, I think we have no other question in the chat.